I got a visit from one of the IT people, and they're looking at discontinuing Panopto. And my only question is there going to be something else? And they said, yeah. So the format will be different. It'll probably still be accessible through Angel, all the rest of it, but kind of had a little panic attack here. It's sometime during the summer. They're trying to extend the contract through the first part of the summer, but for sure next fall. It's an expense issue. I mean, there's other ways to do it that are cheaper. So I told them you would all be happy to see it gone because you hated it and you never used it. Okay, first of our diseases we're going to talk about is retinopathy of prematurity. This is basically a neonatal disease that was formerly known as retrolateral fibroplasia. Gotta love that one, RLF. They found out that really it's not necessarily that the lens becomes fibrotic. There's other things that end up happening. First described back in the 40s, and they noticed that babies that were placed into incubators where oxygen was being driven in, these babies who were premature ended up having blindness as a consequence. It can happen to term babies, but it's predominantly found in premature infants, and especially in those micro-preemies that are at high risk of a good number of things we're going to end up talking about. You don't have the eye being fully developed until really almost term, and the capillaries of the retina begin branching at about 16 weeks. For those of you keeping track, that's about the end of a subglandular period. The capillaries, they basically grow anteriorly, so they start off from the root of the optic nerve, and the capillary network moves out towards the front of the eye, and obviously in premature infants it's not fully developed. So we need to have that capillary network expanding along with the arteries and veins that form with it. Otherwise, the eye is not going to be adequately perfused, and we'll end up having damage done to it. And what retinopathy of prematurity basically is an inability of that capillary network to develop. Okay. What causes it is an elevation in arterial oxygen levels. So when you have a high PaO2, the retinal arteries constrict, and the capillaries can't get blood flow in the process. And it's basically that prolonged exposure that leads to necrosis of the vessels and ultimately damage to the structure of the eye itself. The body attempts to try and create alternate pathways, and what that ends up doing is ending up with some hemorrhaging into the vitreous part of the eye. And that hemorrhaging then eventually leads to scar tissue and ultimately blindness. So here's basically what the situation is. You can see the retinal blood vessels developing on the wall of the retina, and we define retinopathy of prematurity by stages and by zones. Stages have to do with to what extent the retina is becomes detached, and then the zone has to do with where in the eye you're talking about. You can see zone 1 is in the center. Zone 2 is the area surrounding it. Zone 3 is the very periphery. Zone 1 would be the worst that you would end up having. As far as stages are concerned, stage 5 is the worst because that's where you end up having the retina completely detached. So here we can see stage 3 where the lens, and there's this blood vessels growing. The retina here has no perfusion at all and will eventually become necrotic. Here's stage 5 where you basically just have total detachment of the retina, total loss of vision in the process. So what's the cause? High PaO2. Okay. Couple of famous people who have suffered from this. Stevie Wonder was one, and Tom Sullivan, who was a singer-songwriter, kind of comedian. There's a film called "If You Could See What I Hear." He actually became a semi-pro golfer, even though he was blind. Go figure that one. And there's one scene where he was driving a car with his buddies, and the cop stopped him, and he said, "Why are you driving? You're blind." And he goes, "Well, they're all drunk." But the ending of the story is actually a true event, and I won't spoil it for you, but if you watch the movie, it's a very entertaining movie to say the least. So that's ROP. Okay, high PaO2s. Notice I did not say saturations. Okay, so it's just the PaO2 that is the culprit, which leads to the problem of using pulse oximetry to monitor oxygen therapy. An SaO2 of 100% or 99% because of the accuracy of the oximeter could mean a PaO2 of 80, could mean a PaO2 of 300. You just don't know. Transcutaneous got its gain because it measures partial pressure in the process. Okay, so that's let's talk about RDS. Old names for it, infant respiratory distress syndrome, kind of dropped the I and just went with respiratory distress syndrome. Was also known as hyaline membrane disease because the lung itself looks like it becomes fibrotic or hyaline shaped or structured. Still has a pretty significant mortality. It's really due to surfactant production not being there due to lung immaturity. Also, the immaturity of other organ systems go along with that. A reduction in compliance is what you end up seeing. Surfactant washed out, you end up having increased work of breathing secondary to that. The degree the work of breathing goes up is directly dependent upon how much the lung is affected. In the process, because you lose compliance, lung collapses, you end up having a severe hypoxemia being present due to the shunt. And there's multiple organs that are then involved because of reduction in oxygenated blood flow. One thing that we will encounter, or that you see associated quite often with respiratory distress syndrome, is what we're going to call persistent pulmonary hypertension of the newborn, PPHN, formerly known as persistent fetal circulation. And that basically means that those mechanisms where the blood was bypassed in utero, i.e. through the ductus arteriosus and through the foramen ovale, in this case the ductus arteriosus stays open. Because the PaO2 is so low, the body develops pulmonary hypertension. The pulmonary artery system remains as the high pressure system, and blood flow is shunted through the ductus. In the process, you end up having this cyclical process. PaO2 falls, pulmonary hypertension occurs, blood is pushed through the ductus, PaO2 falls further, and the hypertension gets worse and worse. And when we get talking about PPHN, that's where we get some really bizarre gas delivery ideas. Okay. Most of these diseases have comorbidities. So you'll see something where they'll have RDS but also have a PDA. You'll have RDS but they'll also have IVH or NEC or MOUSE as you go along. And yes, you have to know both the letters and what the letters mean. Because sometimes I'll just say the baby has RDS. Sometimes I'll say they'll have respiratory distress syndrome. These are kids that initially look okay. They're breathing okay, and then they go south. They crump. Okay. About a day or so in, they start having a reduction in a worsening of their lung compliance. You start seeing the symptoms develop. And as the disease goes on, if not treated appropriately, you can actually develop some scar tissue on the alveoli. That's where the name hyaline membrane comes. It becomes a diffusion defect in addition to the shunting present. This is just kind of a slide showing how this is just a cyclical pattern that exists. I have progressive atelectasis, develops to the production of hypoxia, lung tissue, the PaO2 falls, peripheral tissues can't get enough oxygen, so they go metabolic, go through the Krebs cycle, they develop lactic acid secondary to having an anaerobic metabolism, in addition to a respiratory acidosis, and you can see it just continually goes round and round and round. And until we stop something by stopping the atelectasis, really there's not much hope for the infant. Fortunately, that is the case. Some clinical signs, again, they're going to be premature. You're going to see very high respiratory rates, well above the 60. That's the upper end of normal. These kids do have grunting and retractions, both substernal retractions and intercostal retractions. Flaring of nostrils, which is always fascinating to watch when the kid's intubated and the nose is still flaring. It's kind of like, dude, you don't have to worry about breathing through your nose anymore because you got a tube in your throat, but whatever. And again, the severe hypoxemia that you end up seeing and all kind of other problems associated with it. What is this? Is this a video? Oh, yeah. You see them? The substernal retractions? So, kid's gonna crump any moment now. On chest x-ray, we have a similar to the ARDS, you have a diffuse whiteout, a radiopaque picture. Basically, it's a presence of massive atelectasis, even to the extent where you can see some aerobronchograms. It's also been described as having a ground glass or fishnet appearance to the chest x-ray, technically called reticulogranular pattern. And you can see here there's not really well-defined airspace. There's a lot of collapsed alveoli. That's what's giving it the whitish color. And you can, I don't know if you can see them real well, but there are some air bronchograms that are there in the process. Treatment, prior to birth, getting mom to kick in some extra surfactant production on the part of the baby by treating with steroids, trying to attempt a lung maturity, trying to keep the baby inside through the process of tocolysis. We talked about using terbutaline as a mechanism to suppress contractions. And once they're born, paying close attention to the thermal regulation that they have, because again, they don't have that, they probably don't have the production of brown fat to keep them warm, and any stress on the system makes that hypoxemia worse. So it, again, just worsens the RDS picture. Surfactant is now prophylactically given. Even if the child doesn't appear to be in distress, we know that there's a delay in the development of the signs and symptoms and the worsening of the hypoxemia. So we'll give some surfactant. You don't need to really know how much we give. I don't care about that part, but...
When would you give it? Just any premature?
Oh, absolutely, any premature baby. Yeah. Anything less than, I think it's 32 weeks, and they automatically give them. It's part of the protocol now.
Can you ever have too much surfactant?
Nah, not really. You just absorb it. You got the real problem. Hold on, Kath. The real problem with surfactant is, remember, I'm ventilating a kid who's very stiff, poor compliance. I'm using pressure ventilation. Uh-oh, here he goes. Now all of a sudden that surfactant reduces the surface tension, compliance improves, that same pressure is going to yield a bigger tidal volume. So you got to be very, very careful when you're ventilating that you're reducing the pressure post-surfactant or at least monitoring the volumes that you're delivering. Yeah, Kath?
RDS can happen even at a full-term baby, so
Usually not.
usually not.
Usually not.
There was nothing,
I'm sorry?
there was nothing written down in weeks what helped, so.
Well, there's this one here. Don't I have one there that says something about usually seeing at prematurity? Yeah. Yeah. You typically don't see it in kids over 34 weeks. There's other things that you might see that mimic it, and we'll talk about that. Targeting a PaO2, I mean, even a 50 PaO2 in a neonate's not a bad PaO2 because, again, in utero there was a whole lot lower than that. So we're not going to just say we have to be 80 to 100 and run the risk of all of a sudden spiking a PaO2 up and the kid going blind because now his PaO2 spiked up and he had some retinal artery issue. CPAP is wonderful for these kids. Just that in and of itself in a lot of cases is enough to reduce the work of breathing, just splinting their airways open and preventing collapse. However, in many cases, they need to be mechanically ventilated. And we talked about some of those rescue therapies, high frequency ventilation, oscillatory ventilation, as well as extracorporeal membrane oxygenation in the worst of worst kids. Those are also ones that probably have a lot of other comorbidities also. Dana?
So you said before, the child receives the actual surfactant. You want the mechanical ventilation, the pressures to be lower.
You'll probably need to lower the pressure because that same higher pressure now will deliver a bigger volume. And you run the risk of having barrel trauma.
Okay.
Really, the problem is just stabilizing the kid until they're a little bit older, until the surfactant that we've instilled and the surfactant that they're developing now has a chance to build up to the levels that are needed to sustain extrauterine life. The problem is the complications. And we talked about retinopathy of prematurity. We'll talk about a couple of other things there too. And as we go through them, you'll see, well, yeah, that can all develop secondary to the hypoxemia that's present within these kids. I'll hold off going through what they are until we get to that point in time, but just recognize that especially kids that are micropreemies, they're going to have, even though we save them and we have, we're able to give them surfactant and breathe for them, sometimes the cure is worse than a disease. Some of the outcomes can be rather poor, or they can get fully better and lead an absolutely normal life, cognitively intact. They often have neonatal picnics where they'll have kids come back, and you'll see somebody who you've kind of watched every year grow up, and he's, getting married now, and wasn't one that you thought was ever going to be viable in the first place. Dude. Got those billy lights on because he's sitting underneath a billy lamp. You got it, baby. Look at that nasal canyon, though. I mean, it's bigger than he is. All right, second one, transient tachypnea of the newborn. TTN. This is one we talked about that occurred primarily in cesarean birth children because they don't have the removal of some of the fetal lung fluid. It's also known as RDS type 2. And you'll see them with basically just an elevated respiratory rate. And what ends up happening is they're trying to get that lung fluid out through the process of evaporation. Here's the problem with RDS and TTN and even neonatal pneumonias. Chest x-rays, they all look the same. Clinically, they have very similar signs and symptoms. So you kind of just need to get a handle on. These kids typically are not premature, in answer to Kathy's question. These are often term babies. So that's one clue that it's not RDS, it's probably TTN. Is the gestational age. Because of the lung fluid being retained, they're at risk for having pneumonia develop, so they'll probably start them on a broad spectrum antibiotic. APGAR scores typically aren't that bad necessarily, and basically just positioning the baby so that draining can occur is one of the primary mechanisms by which we treat it. Just primarily an oxygenation problem, not a ventilation problem. Some O2 and maybe some CPAP is about all we'll end up doing, just waiting for that fluid to clear in the process. And like I said, there's differential diagnosis going on there, and sometimes it's just, well, it's got to be TTN. Yeah.
How long does it take to evaporate?
Day or two. Yeah, it's not long that they're in the NICU, but typically they don't turn south as much as an RDS kid will. Okay, that's 3. Whew, we're on a roll. BPD, bronchopulmonary dysplasia. It's also known as neonatal chronic lung disease, and in a lot of ways, this mimics COPD in the adult. A lot of similar pathophysiological changes. Obviously, they're not smoking in utero, so that's not the cause. However, it's defined as a progressive chronic, meaning ain't going away, lung disease that presents with persistent respiratory problems 2 weeks into life or later, and they have specific radiographic changes, and they're kids who just can't wean from oxygen. And they're literally small lungers, if you want to think of it that way. Yes, ma'am.
2 or 4 weeks?
Oh, I'm sorry, 4 weeks. Excuse me. 28 days. Yeah, you got me. So basically, they've been in NICU for a while. They're typically preterm babies. Again, this is not something that's found with term babes. They need lots of oxygen, and they have all kind of oxidative stress-related issues when they have periods where the PO2 falls. They typically have been positive pressure ventilated, and the possibility of having a pneumothorax or some other barrel trauma there. They typically are an RDS that has a PDA for a prolonged period of time, so they're seriously hypoxemic. And it really depends upon, or the big factor depends upon, how long are they on higher oxygen concentrations and how long are they on positive pressure therapy. The longer those two things are present, high FiO2s, high ventilating pressures, period, the bigger the chance of BPD developing. Okay? And unfortunately, they're all often, because they're on a ventilator and have a bunch of other stuff wrong with them, they're often malnourished in the process. Again, not all babies with RDS develop BPD. Hopefully the RDS resolves and we stabilize them. But you'll know in the first few days that this kid, he's not going to be one that we're going to get off quick. He's one that has a high oxygenation needs. He's one that we're going to be looking probably at BPD being a potential complication of long-term management. What you end up seeing, just like you see in chronic bronchitis, is mucosal hyperplasia, where you end up having increase in mucus cells. The type 1 cell, like an emphysema, coalesce, and you end up with the development of blebs, that coalescing of the alveoli. And again, what I'm talking about there is like an emphysema, where we think of it as a group of grapes. Now all of a sudden the walls of those grapes grow together and you end up with a big plum. And that plum is a very ineffective way to ventilate, and you lose the capillary bed that is there along with that. They can end up actually even having cystic formation of some of these lungs, or the blebs and bullae themselves fill up with fluid. And at the same point in time, they got the typical RDS picture there with collapsed alveoli. So these guys are really a mess. Chest x-ray, yes, Dana?
So would you find like overextension, like
Oh God, yeah. Wait till you see the chest x-ray.
Okay.
Yeah. They're COPD in every stretch of the term.
Okay.
Chest x-ray is going to be honeycomb in appearance. The diaphragms, just like in COPD, are flattened. They also, though, have both these hyperlucent areas where there's cystic formation, as well as a radiopaque picture due to the atelectasis. So it's a mixture of both. Here you see hyaline membrane disease. This is in a 3-hour-old, so still pretty much looking like your RDS picture, a lot of whiteout on both sides. Then as they start to develop, this is day 13. Uh-oh, look at the ribs spreading, the diaphragm flattening out. That's day 19. Here's at 3 months. Very dark, very enlarged heart, very flat diaphragms. Typical of what we would think of an adult as COPD. Okay. And, well, we'll talk about it. Clinically, they're going to be just like your RDS patient, only that it just keeps on getting worse and worse and worse. The hyperinflation occurs. They have spells where their PDA pops back open again, and they end up with a drop in PaO2, and they turn cyanotic, and then it just kind of closes itself back up again. It doesn't stay closed like it's supposed to. But they're just, working real hard to breathe, and eventually the hypoxemia that is there present develops into pulmonary hypertension, and just like in a COPD patient, develops cor pulmonale, chronic heart failure, and ultimately what ends up killing them is the progressive heart failure and ventilatory failure that you see.
So they have a short life.
We've gotten better, but in a lot of cases, yeah,
What's the
they
average
did.
lifespan?
Boy, it's tough to say. You can actually reach it. I mean, it can. Think about what you need to do. If you could stabilize them long enough, they're going to grow more alveoli. So they'll grow more gas exchanging units. It won't be as bad as it once was. I don't know, to be honest with you, on that. I'm sure you could go to adulthood, but you're going to have some chronic lung issues. You're going to probably have hyperactive airways, and you probably have an oxygen needs throughout your life. But I don't know that for a fact. Really, the goal is preventing it, doing everything you possibly can to not have that lung disease develop. Trying to get them off oxygen, trying to get them off the ventilator as quickly as possible. Also, we were, in most cases in critical care, where we're kind of well behind the curve in realizing that we have to feed patients. You want to be able to provide calories to support new growth of lung tissue, new growth of all tissues, actually. They'll often have a very slow wean off oxygen. These are the ones where you'll drop from a liter per minute to 3/4 of a liter per minute to a half a liter per minute over a couple days. Or you'll turn the FiO, you'll put them on a 1/4 liter, and the FiO2 gets weaned from 30 to 28 to 26. So it's a very prolonged, slow period. And again, we talked about limiting the inspiratory pressure. This is where high frequency and CPAP seems to work out well, especially with, in the last 10 years, CPAP has become a much more aggressive approach and not needing to ventilate the kids if you can at all. And again, we talked about keeping the FiO2 as low as possible. And in most cases, just like COPD, we live with a little bit of a lower PaO2. PaO2 of 60 is not bad for these kids. Problem is all the other stuff that develops, just like RDS. They often have GI problems with aspiration, which makes matters worse. Because of the poor nutritional intake, they're prone for bone fractures, secondary to reduction in calcium levels and phosphorus levels. We talked about ROP. There actually can be some hearing deficits that develop because the infections they have require antibiotics that are so potent that they have problems with hearing loss. We talked about pneumothoraces. Depending upon the prematurity that they had and the degree of oxygen resuscitation that occurred at birth, some have cerebral palsy to make matters even more work. And they're like our little CHFers. They're going to have problems with fluid management. And they very easily will go into congestive heart failure. So again, I mentioned as far as death is usually due to cor pulmonale, an overwhelming infection, or just cardiac arrest. So I'll have to find out. That's a good question. I don't know the answer to that. What the duration of care is. These are kids that we'll see long-term wise, as far as having the need to be mechanically ventilated, or at least having oxygen long-term wise. So if you're going to the home care realm, you'll end up having these kids. They're often on diuretics and cardiac meds for the heart failure, and they're frequent flyers. Like I said, just like our COPD patients. Sounds just like them. Now this is a weird one. First of all, the name's cool, Wilson-Mikity. It just sounds like it's got to be a cool disease. And there's some disagreement as to whether or not this is a separate syndrome or not. But it's basically where you end up having a BPD-like picture, but the kid was never ventilated. So that positive pressure that seems to be a trigger for BPD wasn't there, but damn, they look just like a BPD kid. So some people just consider it as another part of the continuum of BPD, but at any rate, I just made mention of it. Pneumonia in the neonate. Again, we know what pneumonia means. Differentiating it from septicemia as far as a blood-borne disorder or blood-borne infection. Meningitis, where it's in the brain and spinal column. UTI we know about. Conjunctivitis, I think you guys know about. Inflammation of the eye. I kind of like the last one there, umphilitis. It just sounds like it's got to be a fun disease, right? Infection of the umbilical stump of the oomph. Pneumonia can occur as a transmission from mom, often various viral infections, herpes, and HIV can be transmitted transplacentally. We can see it at the birth process. I'm sorry, I said that wrong. HIV and herpes are typically with the delivery process, but any viral process can be transmitted placentally. And when you have that membranes rupture and there's time until the baby's delivered, that increases the risk of pneumonia transmission. And then obviously once they're outside, the biggest culprit is us in one way or another. Premature, obviously, at higher risk. Group B strep and E. coli are the two most common organisms that are identified. And we'll talk about some of the complications of pneumonia. They have hypoxemia. They can develop necrotizing enterocolitis as well as intraventricular hemorrhage, and we'll talk about them in a bit. Again, chest x-ray is how we diagnose it, looking at culture and sensitivity of the sputum to identify appropriate antibiotics, just like pneumonia in the adult. You do see, again, MRSA being present. Pseudomonas is a common finding also. And then there's viral things that can be there also. Because a lot of them don't have a really strong immunological system, a lot of things like cytomegalovirus and adenovirus, which are pretty easy to kill off for you and I, because they don't have the full complement of an immune system, they're more prone to it. And did we talk about it? We talked a little bit about it in pharmacology, I know. But the respiratory syncytial virus is one of the more common things that causes bronchiolitis in the infant. And we used to do a whole lot more as far as treatment with ribavirin, but that's kind of, unless they're really, really severe, we're not looking at doing that. But you can see these kids coming in lethargic and grunting, and they actually develop a hypercapnia secondary to the respiratory failure. Okay, one of my favorites, Meconium Aspiration. These are usually not neonates let me rephrase that. These are not premature. These are term or post-term, more often post-term. What ends up happening is the baby becomes a little bit asphyxic, either during or after the onset of labor, and they basically just crap their pants in utero. Screwy way to thinking about it, that's exactly what it is. The anal sphincter relaxes, and the first stool or meconium is released, and we know that we need to do specified suctioning with an endotracheal tube and a meconium aspirator if there's appearance of them having an aspiration present, and treatment with antibiotics. There's some meconium. Nasty looking stuff. The problem again is development of pulmonary barrel trauma if it becomes aspirated, because you end up having that ball valve effect we've talked about previously, and these kids are at a high risk for intraventricular hemorrhage, as we'll talk about in a sec. And there's that ball valve where on inspiration air is allowed to pass by the obstructive element, but on expiration it's not, and the lung becomes hyperinflated. And I think I'll stop there.